Hello, welcome to this webinar. My name's Beth, I'm an orthopaedic sister at the Evelina. We're just going to be talking through acute compartment syndrome today rather than chronic compartment syndrome. So we're just going to focus on the acute and we'll go through what it is, presentation and some of the treatment and management for it. So what is acute compartment syndrome? Acute compartment syndrome of a limb is due to raised pressure within a closed fascial compartment causing local tissue ischemia and hypoxia. And that's from the British Orthopaedic Association. Quite a lot of big words there. So we'll go through in kind of layman's terms what that means. So within our limbs, we have compartments and they're organised so we've got muscles, blood vessels and nerves, and they are bound by a tough layer of connective tissue called a fascia. And the role of the fascia is to keep everything within its correct place in the compartment. So if we have a little look, we've got a cross section of a limb here. So this is the lower leg. And you can see that we've got various compartments, and within those there are muscles, nerves and blood vessels, and they're bound by that connective tissue. So you've got multiple compartments throughout your limbs. The bones do not have a compartment, they're just on their own because they're a nice rigid structure, so they don't need holding in place. So now we know what a compartment is. Compartment syndrome happens when swelling occurs within the compartment, causing raised pressure within. The raised pressure can restrict blood flow through the vessels and cause nerve damage. So if we have a little look at this picture here, if we've got swelling for any reason, and we'll go through what those reasons might be, because the fascia will only expand a certain amount, that means that actually the pressure within the compartment will rise rather than the compartment being able to swell indefinitely. So you can see in the second picture that the space for the nerves and the blood vessels is considerably smaller because the muscles have taken up the majority of the space. And that's going to cause issues for our patients, such as hypoxia and nerve damage. So it's not something that we want our patients to have. So outcomes of untreated compartment syndrome are severe tissue damage, permanent nerve damage, loss of function, necrosis of the tissue, and ultimately it can lead to amputation. So it's a pretty serious condition, and it's going to ultimately be a limb-threatening emergency if we start to see any of those signs. So what can cause it? Lots of things can cause it, and you can see it in multiple kind of areas of clinical practice, but the main things are going to be trauma. So fractures, and particularly if you've got any displaced or compounds or open fractures, they're going to be the ones that are going to be the highest risk. Crush injuries, so if you work in a trauma centre, you're more likely to see these. Any restrictive dressing or cast is going to be a risk, so that can be the same. If you're treating a fracture with a dressing or a cast, or you're using skin traction, those can increase your risk of compartment syndrome. Reperfusion of ischemic tissue is a risk for compartment syndrome. Prolonged immobilization. Burns, particularly if they cover the whole circumference of a limb, because they will restrict the ability for the skin to stretch with swelling, so they're always a big risk. Blood clots can be a risk, but as well as blood clots, if patients on blood thinning medication, they're more likely to kind of bleed and have a hematoma, which can bleed into a compartment and cause raised pressure. And then surgical complications. So if the patient's been to theatre, they're more likely to have swelling as a result of the operation, or if they're having things like washouts and they're using fluid in and around the fascia, if fluid kind of gets into a compartment and causes swelling, that can cause compartment syndrome as well. So those are some of the causes. We're going to look through at what the clinical signs are, and we're going to do a bit of a case study alongside, just to try and make it relevant to clinical practice. So for our case study, we're going to be thinking about Ben, who's a 13-year-old boy. He attends the ED with his mother. He fell off a skate ramp, it was witnessed, and he landed on his right arm. The approximate fall was about 4 foot. On examination, his right arm is visibly deformed and swollen, and it's painful on movement. So he goes for some x-rays, and it confirms a displaced right ulnar fracture. And he's going to be taken to theatre for a manipulation under anaesthetic, probably with a cast application from the emergency department. So from the history here, we've got a traumatic injury. We've got a displaced fracture, and we can see on the x-ray that the fracture is visibly out of line. So there's a risk that that's going to be causing pressure in a compartment within the forearm. So when we're talking through some of the clinical signs, we can have a little think about how Ben might be displaying some of these signs. So there are 6 C's of compartment syndrome, and they are not the easiest to remember. There's some words people have probably never heard of and will probably never use again. But once you understand kind of what you're looking for, hopefully it will all make sense. So they are pain, paresthesia, pallor, poikilothermia, paralysis, and pulselessness. So I'm sure some of those words are not familiar to us, so we will go through in a little bit more detail. So when we talk about pain in compartment syndrome, we talk about it being disproportionate to the level of injury. So, like we said, trauma is a common risk factor. It's common to be in pain when you've had trauma, but we're talking disproportionate to the level. It's often sudden and severe. And the biggest clinical sign of compartment syndrome is that it's pain on passive movement or stretching of the muscles involved in the compartment. So, for example, with Ben in a forearm fracture, if we were to passively extend his fingers or move his thumb, that would be incredibly painful because we're causing movement in the muscles involved in the compartments. And what we know about muscles is when they move, they contract, and that causes them to increase in their size. So if we're causing that, we're going to be causing even more pressure within the compartment. Other clinical signs of pain, if it's not at the site of injury or radiating, because again, that can be a sign of nerve damage, or it might be that a compartment not directly next to where the kind of injury is the one that's affected. So if it was due to a hematoma or something, the swelling might be in a slightly different compartment. Kind of just of note with pain, it's important to think about whether your patient has had any analgesia, and if so, looking at the response to the analgesia as well. So people who work in ED might find that they have patients turn up with a lot of pain with a fracture, but actually they've not had any analgesia yet, and when they're given some simple analgesia, they respond very well to it. However, if you're, say, working on the wards and you're looking after a patient that's had, gone up the pain ladder, they've had simple analgesia and they've been escalated to opioids and they're still in excruciating pain, then that would be definitely very concerning. The guidelines for compartment syndrome recommend that local anaesthesia should be avoided in patients at risk of compartment syndrome. So those of you that work in theatres or recovery might notice it's very rare to give nerve blocks or local anaesthetic in these kind of high-risk patients, so fractures and things, because if the patient has numbness due to a like nerve block, then you wouldn't necessarily see that initial sign of compartment syndrome. Our next P is paresthesia, which refers to tingling or numbness. So thinking about with paediatric nursing, depending on the age and vocabulary of our patient, they might use different phrases. They might call it pins and needles. They might refer to a kind of burning or itching sensation, depending on what kind of vocabulary they have and how they're able to verbalize that. So just be aware that, they might even just refer to it as a funny feeling. So trying to think about what are they actually trying to tell you. They can have reduced sensitivity to touch in the affected limb, and specifically the sensitivity is reduced to kind of sharp objects or sharp sensation. So often in a tendon hammer, which most wards should have, hopefully, most neuro and orthopaedic wards will have one, and hopefully A&E. The opposite end to the actual rubber hammer has a bit of a sharp point. I don't know if anyone's ever seen that and noticed it before, but that point on the end of a tendon hammer can be used, and if you run that along the limb, patients should be able to feel it. But if they can't feel that, then that would be very concerning. If you don't have a tendon hammer, you can often use Bic biros often have quite a sharp pen lid. If you use something like that, you might get a similar effect. Don't go getting a needle or anything and running it. We don't want to cause the patient any harm. We just want to assess with a blunt object. And if the patient is suffering with this, then that is a sign of neurological damage, so damage to the nerves, which is concerning to us. Our next P is pallor. So that refers to a pale or discoloured skin, so maybe kind of bluish or purplish. If we're seeing pallor, we would expect to see our capillary refill time is prolonged. So you check your cap refill as well as looking at the colour. And it's indicative of poor tissue perfusion. So again, it's not a sign that we want to see. Just being aware, particularly if you are in an area like A&E where you're doing the initial assessment, you want to be assessing it against the other limbs. So a patient with kind of widespread pallor, that would be concerning, and that wouldn't be compartment syndrome. You might be looking at other kind of respiratory causes of that. So it's pallor specifically to the affected limb. So just making sure you're comparing it against other limbs. Poikilothermia, very posh word, which basically means inability to regulate body temperature. So what that means is that the limb will feel cool. Again, you need to compare it bilaterally to the other extremities. Orthopaedic theatres are famously quite cold, so if you're looking after a patient post-op, they may just generally be cold from their time in theatre. So if you think it's just that they've got a low core body temperature, then using a bear hugger or blankets just to see if that changes. And if the other limbs warm up but not the limb in question, then that is concerning. Again, with A&E, if you're seeing a patient that's just arrived from a roadside trauma, they may just be cold as well. So just bear that in mind when you're assessing it. And they recommend using the back of your hand and feeling kind of up the limb. You might feel a demarcation line, which might be kind of around the level where the compartment syndrome is. Paralysis is our final P, and that refers, sorry, it's a penultimate P, refers to an inability to move all or part of the limb. So you'd ask the patient to perform certain movements. So in a forearm or elbow fracture, you would often ask the patient to touch their thumb to each of the fingers on their hand, kind of making an OK sign. And that would assess their ability to move all their fingers. And to assess their power, while they've made the OK sign, you would then try and kind of pull it apart with your finger, and they should be able to hold it together, or at least have resistance. You just need to bear in mind what the child's baseline is. So femoral fractures are quite common in our children with neurodisability, like cerebral palsy or Duchenne's muscular dystrophy. So if a patient is presenting with that and you're asking them to wiggle their toes, are they actually able to wiggle their toes, or do they not have that level of fine motor movement? So just kind of speaking to the patient and the parents on what their normal movement is, comparing it to their other limb, although again, bearing in mind that cerebral palsy might not be the same. If they've got bilateral cerebral palsy, they might be able to move one leg fine, and the affected leg might be the one that they can't wiggle their toes on. So just make sure you're aware of what the baseline is when you're recording that. And also just being aware of restrictive casts. So if they were already in a full leg cast and you're worried about movement, you're only going to really be able to get them to wiggle their toes. You're not going to be able to see them extending and retracting their foot. So you just have to kind of assess within the limits of what you can. And paralysis is a very worrying sign because that's often a sign of permanent damage. So signs of initial nerve damage would be your paresthesia, and then by the time we get to the stage of paralysis, that's quite a late sign. And then the final P is pulselessness, which refers to the absence of a pulse distal to the injury, so beyond the injury. So for a forearm fracture, you'd be looking at the radial pulse. For your leg fractures, you'd be looking normally at the posterior tibialis or the dorsalis pedis, which are the pulses at the back of your heel and on the top of your foot. Again, whether you can feel a pulse will depend on access. So if a patient is in a cast, it's often not possible to pulse. In a back slab, depending on where the kind of hard part of the POP is, you might be able to feel a pulse. So just make sure you assess whether you're going to be able to obtain one. And if you are, document what you find. So you can grade pulses. There's a couple of different scales out there. But the main thing is you want to be documenting whether it's an absent pulse, a weak pulse, a palpable pulse, or a bounding pulse. And that will help you set a trend. So if it starts off with a nice bounding pulse and it becomes weak and thready, that would be quite concerning. Again, with all these, you'd want to kind of compare that to the other limb as well. A patient with kind of bilateral or widespread weak thready pulses, particularly if they're a trauma patient, you may want to do another A to E assessment and make sure that they've not got some kind of bleed that's been missed, because it could be other causes. But if it's a specific to the site of injury, weak or absent pulse, that's very worrying. Pulselessness is actually a very late sign, because in order for the pulse not to be present, the pressure within the compartment has to be greater than arterial pressure, because it's going to cause arterial collapse. So that's actually incredibly high pressure if we think about the pressure within the arteries. So by the time we get to that stage, we're at the point where the limb is at risk. So hopefully with our other Ps, we will spot that something is wrong before we get to this point. So moving on to think about how we monitor compartment syndrome. Patients at risk of compartment syndrome should have a neurovascular assessment documented hourly. Pain is the key clinical finding for compartment syndrome, so it's important to document pain scores and response to analgesia alongside your neurovascular observations. Changes in pulse, movement and sensation are late signs, but they're very helpful in documenting, because it helps you assess that it's a nice well limb. So although they don't necessarily tell you about early signs of compartment syndrome, they will tell you about the vascular status of the limb. I don't know what different trusts use in terms of their neurovascular observations charts, but this is kind of an example. This is the RCN's neurovascular observation chart. So if your trust doesn't have one, you can access this by Googling RCN compartment syndrome. It's one that can be used. So their one focuses a lot on pain. Our trust's neurovascular obs chart doesn't actually ask about pain, so you need to be documenting that separately. But bearing in mind that pain is the key clinical finding, it's quite important that it's documented. So it's good to have it with the rest of your neurovascular obs. You can monitor pressures here, which again, I don't know about other trusts, but our trust doesn't routinely do for compartment syndrome. But the key is that you're documenting whether you can feel a pulse and what the quality of the pulse is, documenting about the sensation and whether that's varied from baseline, and documenting your skin colour and capillary refill time. So they will probably vary from trust to trust, but hopefully the basics will be there to help you assess for the risk of compartment syndrome. So going back to our case study of Ben, you're looking after Ben on the ward, and he's post-op, having had his manipulation under anaesthetic and application of cast to his right arm. His neurovascular observations at 1 hour post-op are as follows. So he's scoring his pain 2 out of 10. His fingers are nice and pink. His capillary refill time is less than 2 seconds. The fingers are warm. He has normal sensation and normal movement, and you're unable to assess a pulse because both his radial and ulnar pulse are covered by the cast. So based on this, hopefully everyone is nice and reassured that we've got very low chance of compartment syndrome. We don't have any of the key clinical findings. He's pretty comfortable with a pain of 2 out of 10, so that's quite reassuring. However, 2 hours later, Ben's mum approaches the nurse's station as she's worried Ben is in a lot of pain. You go and review him, and he's had paracetamol intra-op and ibuprofen within the past hour. So he's had regular simple analgesia, which should be helping. You decide to complete some neurovascular obs, and they are as follows. His pain is being scored as an 8 out of 10. The colour is still nice and pink, so he's got good perfusion, and the cap refill is less than 2 seconds. The fingers still feel nice and warm. He's got normal sensation. His movement is normal, but he's complaining that it's painful when he does move, so he's very reluctant to do it, and you're still unable to assess the pulse. So much more concerning here that he's complaining of a lot of pain. We've reviewed what analgesia he's had, and there is scope to escalate it, but it is concerning. It doesn't give us much information here about what the nature of the pain is. So if you were doing your assessment, you might want to try and find out a little bit more from him, getting him to describe whether he's experiencing any radiating pain, and kind of exactly where in his arm it is that he's feeling the pain. And it doesn't specify, but it doesn't seem that he's experiencing more pain on passive movement, which is somewhat reassuring. You bleep the on-call orthopaedic junior doctor and they're just about to scrub into theatre with the on-call registrar. So they advise you to administer oral morphine and continue to assess neurovascular status. And they tell you to try and bleep back if there's any more problems. So a bit of a brush off. 30 minutes after you've given oral morphine, the neurovascular observations are as follows. He's now in 10 out of 10 pain. So despite increasing analgesia, the pain has increased. He still has nice pink fingers, but the cap refill is now 2 seconds rather than less than 2 seconds. So still normal, but it has changed. His temperature is warm. He's now complaining of pins and needles in his wrist and fingers. He still is able to move, but it's with extreme pain. So he is very, very reluctant to do it. He will only twitch his fingers. He won't do full movement, which is what he was doing previously. And you are still unable to assess the pulse, sorry. So hopefully from that, everyone is highly concerned that we have got some clinical indicators of compartment syndrome here, namely with the increasing pain that's resistant to analgesia. We've got some paresthesia, and we've got pain on passive movement. So very concerning. So let's talk a little bit about the managed compartment syndrome. So we have some ideas about what we might want to do for Ben. So patients with symptoms or clinical signs of compartment syndrome should be escalated to an orthopaedic doctor immediately. So because Ben's condition has changed slightly, we would want to re-escalate. All circumferential dressing should be removed. So if you had a patient on skin traction or just with a simple bandage, you would be able to remove that yourself. If it's a patient with a cast, you may need some support from the orthopaedic team or senior nurses in order to remove that. Not all kind of ward nurses have had training to remove casts. The limb should be elevated to heart level if possible. And re-evaluation should take place within 30 minutes. So anyone at risk of compartment syndrome should be having neurovascular obs hourly. If you then start to see clinical signs of compartment syndrome, you should be increasing the frequency to every 30 minutes. And then it is possible to measure compartmental pressure on the RCN neurovascular obs chart. If you remember, I mentioned you can record pressure. So if it's inconclusive whether you think it's compartment syndrome, then you can measure the compartmental pressure, and it will help to guide whether there is increased pressure within compartments. It's not something, I don't know of any nurses that are trained to do this. This is something more that an orthopaedic registrar would come and do. And again, with a patient with a cast on, you're going to need to cut the cast before you're able to do this. So from an initial management point of view, you'd be looking at removing any dressings you can, elevating the limb and increasing the frequency of your observations. Also just providing some reassurance to child and family, because it's obviously very uncomfortable that the child's in a lot of pain. I'm sure the parents will be very distressed and the child is going to probably be quite scared. So the treatment for compartment syndrome, if we are confirmed, is to have an urgent surgical decompression known as a fasciotomy. So incisions are made in the infected compartment to relieve pressure. So they need to cut through the skin, fat and muscle layers into the fascia and to actually open the fascia. So we were saying earlier that the fascia is a rigid structure, so it doesn't allow for much expansion when there's increased pressure. So if you cut it, it helps to relieve the pressure within the compartment. Any necrotic muscle and tissue is excised. So hopefully we've caught things nice and early and we haven't got to the stage of necrosis. But it might be the case, in which case they would need to do that. And then according to the guidelines, they should go for a re-exploration within 48 hours or sooner if indicated. So what would normally happen after a fasciotomy is they would leave the fascia open. So patients would return to wards and they would have the dressing packed normally, but it would be open. So they would go within 48 hours to have a re-exploration, assess any further tissue or muscle damage that might need further excision, assess whether the cause of the compartment syndrome is resolved and the pressures have reduced, in which case they would then attempt to close the fascia. They might need plastics involvement to be able to do that, particularly if there's been a lot of excision of tissue, or if the fascia has been open for longer than 48 hours. So if it's not resolved within that time, then you're likely to need plastics involvement. They might need to use vacuum assisted closure. So I don't know if your trusts use vac dressings, where you kind of use a foam dressing to pack the wound, and then vacuum helps to slowly close it over time. I've got some diagrams here. If you Google fasciotomy, it's quite graphic. There is lots and lots of images. So I went with a clip art. Don't know how squeamish people are. So you can see in this picture, they've made multiple incisions. So any affected compartment needs to be opened. If you're only opening one, then the symptoms of compartment syndrome and therefore the ongoing sequelae will continue. So you want to open any at risk. And you can see that they've gone through the skin layer right down into the fascia, and that's been left open. Compartment syndrome is a surgical emergency. I don't know if you've heard the phrase life or limb threatening. It's certainly a limb threatening emergency. So surgery should occur within 1 hour of a decision to operate. So all trusts run a priority list. So they should be ready to go and on the table within 1 hour of that decision to operate. So going back to Ben, you're highly concerned that Ben has acute compartment syndrome. So as we said in the management, you're going to bleep the orthopaedic team again. Unfortunately, they're still scrubbed in theatre. So you speak to a very helpful scrub nurse who passes on the message that they recommend elevation and splitting the cast, as we discussed. So in this scenario, we'll say that you're competent to split the cast. So you're going to make a split, and you're going to make sure that you actually relieve the pressure on the wool that's inside the cast as well. A lot of people think just splitting the either plaster or the fiberglass will be enough, but like we said, it can be a restrictive dressing. So if they've wrapped the wool layer too tight, that could be what's causing some problems. So make sure you split everything. And in this instant, you're going to preemptively make Ben nil by mouth and begin a pre-op checklist. So as we know, if it's a limb-threatening emergency, we want to get this child to theatre as soon as we can. So anything you can do to help make that process nice and quick and smooth is definitely very helpful. After splitting the cast and elevating the limb, the neurovascular observations are as follows. The pain is still a 10 out of 10. The limb is now pale, and we've got a cap refill of 3 seconds. So that perfusion has reduced. It's still warm. He's still complaining of pins and needles. He's now unable to move without extreme pain. So even if you passively rotate his thumb, for example, he's in agony. And a pulse is now palpable. So now we've split the cast, you are able to feel a radial pulse. So that's still present. So from these neurovascular obs, we've still got our key clinical finding of pain on passive movement. We've started to see a reduction in perfusion and the nerve function, but we've still got palpable pulses and we're still warm, because those are our late signs. So thankfully we've caught it quite early. Ben is reviewed by the on-call registrar 15 minutes later. So they finished in theatre and come straight to the ward because of your escalation. Since elevation and splitting the cast, Ben continues to complain of pain and on passive movement. A decision's made to take him to theatre for exploration plus minus a fasciotomy. Theatre's booked and you take him to theatre 20 minutes later. He undergoes a fasciotomy of the affected compartment and is found he's got bleed inside, which has caused the compartment syndrome. So that's why splitting the cast didn't help, because it wasn't the restrictive dressing and cast that caused it. He actually had a intracompartmental bleed, which is what caused the raised pressure. He returns to the ward for ongoing care before further exploration in 48 hours' time. And you continue hourly neurovascular obs in this time. So he's still very high risk of redeveloping compartment syndrome. So you want to make sure that you continue to assess regularly. So as a bit of a summary, acute compartment syndrome is a surgical emergency in which the limb is at risk. Patients with injury, trauma, or circumferential dressings or burns are at greatest risks. And particularly we know that any displaced fractures or crush injuries are kind of your highest risk. At-risk patients should be monitored closely for signs of compartment syndrome and their neurovascular status documented. I think some people don't know whether they need to do neurovascular obs or not. Ultimately, it doesn't cause the patient any harm. So if in doubt, just do your neurovascular obs and document them. And then any changes, you'll have a kind of baseline to compare it to. And then any extreme pain on passive movement should be escalated to the orthopaedic team as a clinical finding of compartment syndrome. So that is the key one. And then just a summary of our 6 Ps. Our pain is our kind of most common and the most concerning clinical finding. So it's sharp and deep, and it particularly worsens on passive movement and stretching. Paresthesia is probably our second most common. It's the feeling of pins and needles, which will eventually result in complete numbness. Pulselessness is a very late sign, which we will hopefully never see, and that is when our pressure is so high that it causes arterial collapse. Pallor and poikilothymia are going to be other signs we're looking for, so that's why we're assessing for the temperature, colour and the cap refill. And then paralysis is another very rare and late finding, in which the ability to move, so not just reduced movement because of pain, but the actual inability to move the limb at all is present. So that's the end of the presentation. Hopefully that's given you a little bit more of a background on what compartment syndrome is, what you'd be looking for, and how that might affect your clinical practice. So in terms of signs you'd be looking for in your patients, things you'd document, and when to be concerned and escalate to your orthopaedic team.